Okay, welcome to the first video of ECG interpretation made easy video series. By the end of this video series, I'll make sure that you have mastered all the important ECGs, all the high yield ECG rhythms and their abnormalities. We will solve ECGs together, we will learn ECGs together, we will interpret different 12 lead ECGs. First of all, what is ECG? ECG is basically electrocardiogram in which you place certain sensors on the human body and you detect the electrical activity of the heart. That electrical activity of the heart is recorded in a piece of paper that is called as ECG. Basically, in our heart, there is SA node, and that SA node produces electrical signals, and those electrical signals cause contraction of the atria. Those electrical signals travel from SA node towards AV node, and AV node sends those signals toward the ventricles and causes contraction of the ventricles. It sends signals via right bundle branch and left bundle branch. These bundle branches further divide up into small fibers called as Purkinje fibers, and when the electrical signal goes through these fibers, they cause contraction of the ventricles. Whenever there is any abnormality in this electrical circuit of the heart, abnormalities as in myocardial infarction, abnormalities as in hypertrophies, abnormalities as in ventricular tachycardias, ventricular fibrillations, we will learn all these ECGs. Now in your wards, you would have seen an ECG strip like this with all different leads capturing the activity of the heart. That is called as a 12 lead ECG. What does 12 lead ECG means? 12 lead ECG means that we are capturing the activity of heart from 12 different angles. We are looking at the heart electrical activity from 12 different angles. That is called as a 12 lead ECG. Now where does these 12 leads come from? These leads are basically divided into hexaxial leads and precordial leads. Hexaxial leads include lead 1, 2, 3, AVR, AVL, AVF. Precordial leads include V1, V2, V3, V4, V5, V6. Now first we will discuss the hexaxial leads. Now to get the hexaxial leads, we place certain electrodes on the human body parts, and these electrodes capture the electrical activity of the heart. To get lead 1, we place positive electrode on the left arm of the patient and we place the negative electrode on the right arm of the patient. That is the lead 1. Now remember, this positive electrode acts as a camera, and this positive electrode is basically the electrode that is looking at the heart from the positive direction to the negative direction. So the positive electrode always acts as a camera, and it is looking towards the negative side, and it is capturing the electrical activity of the heart. Now same applies for lead 2. In lead 2, we place the positive electrode on the left foot of the patient and we place the negative electrode on the right arm of the patient. And this positive electrode is acting as a camera, and it is looking at the heart from the left foot towards the right side. So it is looking at the heart from beneath. So we are capturing another angle of the heart, another view of the heart. Coming to lead 3, in lead 3, we place the positive electrode on the left foot of the patient and negative electrode is placed on the left arm of the patient. So we are capturing another angle to look at the heart from positive to negative. The positive electrode acts as a camera. So this is how lead 1, 2, 3 are placed, and these are placed at different locations and they are looking at the heart from different angles. Now this is another picture showing lead 1, 2, 3, and these leads are looking at the heart from 3 different angles. Now what mathematicians and physicists did is that they performed certain calculations and they derived 3 more leads from these very leads. And those leads are called as augmented leads. Augmented leads include lead AVR, AVL and AVF. And for AVR, AVL, AVF, you do not need to put any more electrodes on the patients. These 3 leads are basically derived from lead 1, 2, 3. From the vectors of lead 1, 2, 3, these 3 leads are derived. These mathematicians and these physicists performed calculations and they derived 3 more leads. These are leads AVR, AVL, AVF, and they actually gave us 3 more angles to look at the heart. These 3 leads are actually acting as a camera, and heart is acting as their negative electrode, and these leads are also looking at the heart from 3 different angles. So this is so amazing that we put 3 different leads on the patient, and from those 3 very leads, we are actually getting 6 different views of the heart. 3 views from the leads that we place and 3 views from the math of those leads. We get another 3 angles. Those leads are called as augmented leads, or lead AVR, AVL, AVF. These leads are actually called augmented leads because when they were deriving these leads from the vectors of the main leads that we placed, their voltage was actually low. So what ECG machine did was that they increased the voltage from ECG machine so that we get a proper tracing on ECG paper. So these AVR, AVL, AVF leads are basically derived from these leads and their voltage is low. So we increase the voltage a little bit so that we get a proper beautiful tracing on the ECG strip and we get a different angle to look at the heart. That is called as hexaxial leads. In hexaxial leads, we have lead 1, 2, 3, AVR, AVL, AVF. Now what we will do is that we will move these vectors and we will make them pass through the heart, and then you will get an idea that where these leads are actually looking at. If you pick up lead 1 and you place it over the heart, it will look like this. If you take lead 2 and you place it over the heart, it looks like this. You do the same with lead 3, you pick it up, you put it over the heart, and we get an access plane like this. You do the same with these leads, the augmented leads. You take the lead AVF and you place it over this axis. You take lead AVL and AVL looks like this. You take lead AVR and AVR is looking like this. Now all these leads are looking at the heart in different direction. Lead 1 is looking in this direction. Lead 3 is looking in this direction. Lead 2 is looking in this direction. Lead AVL is looking at the heart from beneath. Lead AVL is looking from this direction. So we are capturing the electrical activity of heart from all these sides. Now coming to precordial leads. Precordial leads also has 6 leads: V1, V2, V3, V4, V5, V6. Now if you would have noticed, we were looking at heart in these hexaxial lead in just one plane. We were looking at the heart from this side, or we were looking at the heart from above or below, but we did not have any lead that was looking at the heart from the front. In hexaxial plane, we had all the leads that were looking at the heart in this plane, but we did not have any lead that was looking directly at the heart from the front. So the precordial leads are the leads that we place on chest, and these chest leads, these precordial leads, actually look at the heart from the front, and hexaxial leads look at the heart from the sides. So this is the concept. Now we are getting 6 more angles to look at the heart. We place chest leads, also called as precordial leads. These precordial leads are placed on chest and you capture the electrical activity of the heart, and these precordial leads are actually looking at the heart from the front. Now, how will you place these precordial leads? Basically, you palpate the sternal notch or jugular notch and you keep going downwards. You will feel that there is a small ridge called as angle of Louis, also called as sternal angle, where manubrium joins the sternum. And when you go on the right side, you will feel that there is a rib present. Beneath that rib, there is second intercostal space. Then you palpate the third intercostal space and you palpate the fourth intercostal space. And on the fourth intercostal space, beside the sternal body, you place the V1 lead. So you place V1 in the fourth intercostal space beside the sternal body. In the same way, you place V2 in the fourth intercostal space on the left side beside the sternal body. You place it beside the sternal body because the fat content over here is less and we can capture the electrical activity very well. Then you don't place V3 now. What you do is that you move to the fifth intercostal space. You were in the fourth intercostal space on the left side where you place the V2. What you do is that you palpate the fifth intercostal space, and what you do is that you place the V4 in fifth intercostal space. Then between these V2 and V4, when you have already placed V2 and V4, between these V2 and V4 you put the lead V3. Now what you do is that in the direction of V4 you put V5 and you put V6. V6 is placed in the mid-axillary line, and most of the time you will have to ask the patient to move their arm away to put V6. If you do not ask the patient to move their arm away, most likely you are putting V6 in the wrong space. So V1, V2 in the fourth intercostal spaces, V1 on right side, V2 on the left side, V4 in fifth intercostal space, and V3 is placed between V2 and V4. V5 and V6 are placed in the same line of V4, V5 and V6. V6 is placed in the mid-axillary line. These are the locations of precordial leads. Now, when you have placed these precordial leads, these leads are looking at the heart in this direction. They are capturing the electrical activity from the front. Hexaxial leads are looking from the sides. Precordial leads are looking from the front. V1 and V2 are called as septal leads because they look at the septum of the heart. Lead V2, V3, V4 are called as anterior leads because they are looking at the anterior part of the heart. Lead V4, V5, V6 are called as lateral leads because they look at the left lateral side of the heart. So whenever there will be an MI in the left lateral side leads, you will capture it in lead V4, V5, V6. Now whenever there is MI in septal leads, there will be changes in lead V1 and V2. So these are more 6 angles to look at the heart. Now on an ECG strip, these leads are placed in this direction. Lead 1, 2, 3, AVR, AVL, AVF, these are hexaxial leads, after which precordial leads are placed. V1, V2, V3, V4, V5, V6. This is an ECG paper in which you can see lead 1, 2, 3 and all these leads placed in the same way. Now, if you have noticed, beneath these leads, you have another strip called as a rhythm strip. In this rhythm strip, one lead is picked up from here and that lead is spread out beneath these leads. That is called as a rhythm strip. What is the use of rhythm strips? We will discuss it in our video in abnormal rhythms of ECG. You can use lead 2 as a rhythm strip. You can also use lead V1 as a rhythm strip. Now, if you have understood these leads, you will be able to answer these simple questions. Now, if I ask you, which are the leads that are looking at the inferior surface of the heart? What are the leads that are looking at the inferior surface of the heart? Pause the video and think over it. Leads that are looking at the inferior surface of the heart are lead 2, 3 and AVF. And if there is myocardial infarction in the inferior surface, if it is an inferior wall myocardial infarction, lead 2, 3 and AVF will show changes. Lead 2, 3 and AVF show us the inferior wall of the heart. Now, if I ask you, what are the leads that are looking at the septum? These are lead V1, V2. What are the leads that are looking anterior aspect of the heart? These include lead V2, V3, V4. So V1, V2 looks at the septal part. V2, V3, V4 looks at the anterior aspect of the heart. If there are changes in these leads, it's most likely an anteroseptal MI. Now, if I ask you, what are the leads looking at the lateral side of the heart? These are lead V4, V5, V6. And in the axial lead, what are the leads that are looking at the lateral side of the heart from positive to negative side? These are basically lead 1 looking at the lateral aspect of the heart from positive to negative. Lead AVL looking at the lateral aspect of the heart from positive to negative. So lead 1, lead AVL are looking at the left lateral aspect of the heart. Lead V5, V6 are also looking at the lateral aspect of the heart. So if there is a lateral wall MI, you will see changes in lead 1, lead AVL, lead V5, lead V6. Now this is the importance of understanding the different leads of ECG, because when you know about what lead represents which part of the heart, you can easily tell where the problem in the heart is. If there is problem with lead 2, 3 AVF, it means that there is inferior wall problem. If there are changes in lead V1, V2, it means it's a septal wall problem. If there are problem with lead V3, V4, it's an anterior wall problem. Lead 1, AVL, V5, V6, if they show changes, it means that the problem is with the left lateral part of the heart. Now, this is another picture to see how these hexaxial leads are looking at the heart in this plane and how lead V1, V2, V3 are looking from the front. Now, if we look at the normal flow of current, normally current flows from SA node to AV node to bundle branches to Purkinje fiber. And if we take a vector of flow of this current, that vector will be in the left lateral direction. That is the normal flow of current. And if there is an electrode present directly in front of this current flow, that electrode, that positive electrode, that camera will show a positive deflection. If there is a lead that is present in front of this current flow, that lead will show a positive deflection. And if a lead is present at the back, if a lead is present behind the current flow, that lead will capture a negative deflection, because the current is moving away from this lead, that will show a negative deflection. Current is flowing towards the lead, that shows a positive deflection. Now, if you see in this picture, you will see that the current is flowing in this direction, the normal vector of the heart in the left lateral direction. Which lead is lying just in front of this current flow? It is the lead 2. Lead 2 will capture the most prominent positive deflections because it is present directly in front of the current flow. And which is the lead that is present behind this vector? That is the AVR. AVR is present at the back of the current flow. So it will show the most prominent negative changes. The AVR will have negative deflections. The lead 2 will have positive deflections. Now, if you look at this ECG, there is P, QRS and T wave, and it is very prominent and beautiful in lead 2. And if you look at AVR, AVR is lead 2 but upside down. AVR is fully negative. AVR is just the copy of lead 2, but it is fully upside down. Now, what's the importance of understanding this thing? Now, if in any ECG, if AVR has a positive deflection, it's abnormal. It means that the axis of heart has changed. The current flow of the heart has changed. Current flow has changed its path. Therefore, AVR is showing a positive deflection. So AVR tells us about the direction of current flow. If AVR is fully upside down, if the AVR is fully negatively deflected, it is normal ECG. And if AVR is showing any positive deflection in it, it means that there is a problem with the heart axis. The current is not flowing in the right direction. If you zoom in, you see the lead AVR is fully upside down, and it's a normal finding. A positive deflection in AVR shows that the current is not flowing in the right direction. The current is flowing in the wrong direction. The axis has changed. Now on ECG, we have an isoelectric line. Isoelectric line means that there is no electrical activity, and whenever current flows in that direction, there will be positive deflection. When the current flows in the opposite direction, there will be negative deflection. And you see a classical PQRS-T wave. Where does this PQRS-T wave come from? Peak wave shows atrial depolarization. When the current flows from SA node towards AV node, it causes contraction of the atria. The spread out of current in the atria represents atrial depolarization, and it appears as P wave on ECG. Now, the current flows from SA node towards the AV node, and from AV node, the current goes towards the bundle branches. And in the bundle branches, remember, the left bundle branch depolarizes first, and the right one depolarizes later. What left side does is that left side gives current to the right bundle branch block, and for a small period of time, for a short period of time, current flows from left side towards the right side. Current is flowing from left side to right side to depolarize the right side, because right side has thicker fibers. They depolarize first, they depolarize rapidly. And when they depolarize, they send signals towards the right side. And when they send signals towards the right side, you will see that the current moves in this direction. That is captured as small Q wave on ECG. A small negative deflection that appears as Q wave, because the current is flowing in the opposite direction, not in the downward direction. That's why we see a negative deflection. After that, the current flows forward in the direction of lead 2, and you will see a beautiful QRS complex, a beautiful tall QRS complex that shows ventricular depolarization. After that, there is ventricular repolarization, and ventricular repolarization vector has also the same direction towards the lead 2. Therefore, you see a positive deflection that is called as ventricular repolarization. P wave shows atrial depolarization, QRS shows ventricular depolarization, T wave is ventricular repolarization. Now on ECG paper, you see an ECG strip like this, and on ECG paper, you will appreciate large boxes, and in these large boxes, you will see these small boxes. Each large box is a square composed of 5 small squares in width and 5 small squares in height. Each small box is equal to 1 millimeter square. It means that one small box has 1 millimeter height, 1 millimeter width. 1 millimeter square, very important. And that one small box in time is equal to 0.04 seconds. Very important, must memorize this. One small box is equal to 1 millimeter square, and one small box is equal to 0.04 seconds. Now each large box is composed of 5 small boxes, so we multiply these numbers with 5. 5 multiplied by 1, 5 millimeter squares. So the size of large box is 5 millimeter square. 5 multiplied by 0.04 seconds is 0.20 seconds. So one large box represents 0.20 seconds. These, remember the small box measurements, and it will be very easier for you, because this is where we will detect the PR interval prolongation, QT prolongation, QRS prolongation, wide, narrow QRS. This thing is very important, must memorize this. Now I'll briefly go through the P wave. P wave should be smooth. A normal P wave should be round and upright, with a duration of 0.10 seconds or less. That's why I was stressing on the last slide that you should memorize the size of small boxes. Now coming to PR interval. PR interval starts from the start of P wave to the start of R wave. This is PR interval. PR interval is very important. PR interval should be of 0.12 to 0.20 seconds, which is equal to 3 to 5 small boxes. So that's why I was stressing on the previous slide. Memorize those numbers. PR segment. Remember, PR interval is all the waves and lines, and PR segment is the line. Remember, PR segment is the line. PR segment is depressed in pericarditis. Now coming to QRS complex, a normal QRS complex should be narrow. Narrow means that the small boxes should be less than 3. A normal QRS is narrow. It has steep angles and sharp points. That is a normal QRS. A wide QRS is abnormal. We will discuss we tack in those abnormal rhythms. There will be wide QRS complexes. Now a QRS complex can present in different forms. A QR wave, where the Q wave is present, R wave is present, and the S wave is absent. It is called as a QR wave. Another form of QRS is RS wave, where the Q wave is absent. Another form is RS wave, where the Q wave is absent and there is a huge S wave that is written as small r and S wave. So these are all the different forms of QRS complexes. We'll go into more details in the subsequent videos. Now coming to ST segment. This is ST segment. Remember, segment is the line. Interval has all the squiggles and waves in it. Segment is only the line. PR segment, ST segment. ST segment should be at isoelectric line. 1 millimeter variance in one lead is normal. 1 millimeter is one small box, and its length is 0.020 seconds. Coming to T wave, remember, T wave should be asymmetrical. A normal T wave is asymmetrical, where there is slow rise and a fast fall. A symmetrical T wave is not normal. A symmetrical T wave can be seen in ischemia. A symmetrical T wave can be seen in head injury, in electrolyte abnormalities. Symmetrical T wave is abnormal. QT interval. QT interval starts from the start of Q to the end of T wave, and it shows all of that ventricular activity, ventricular depolarization and repolarization. Its rate, its size is 0.33 to 0.44 seconds. It's also heart rate dependent. Where the heart slows down, this will prolong. Where the heart is rapidly beating, this will shorten. U wave is sometimes seen after the T wave. It has no clinical significance, and it is sometimes seen in patients with hypokalemia. But sometimes even patients of the normal potassium, these wave can be seen. It has no clinical significance. Now, before going into the summary, please click on the subscribe button. We talked about the normal flow of current, 12 lead ECG, hexaxial leads. What does these hexaxial leads represent? Where does these AVR, AVL, AVF derive from, and how do they show? The precordial leads and their importance. What do the leads represent? And then we discussed about the PQRS. Where are these derived from? We discussed about the graph, the big boxes, small boxes, normal P wave, PR interval, PR segment, QRS complex, ST segment, QT interval.